Welcome back to Mapping Healthcare on KDRT 95.7 FM in Davis, California, where a medic with a map explores healthcare around the world, highlights people who improve it, and shares what we can learn from them. This is your host, Dr. Sheikh. Today we're talking about a topic that takes a look at when life begins, and why for so many women that beginning is also an end. Every single day, over 700 women die from causes related to pregnancy and childbirth. That's one death every 2 minutes. Howie is a woman who lives in a rural village, miles from the nearest clinic. She starts to bleed heavily after her baby is born, something called postpartum hemorrhage. A global public health framework called the 3 delays helps us understand that her story is a common one. First, there's the delay in deciding to seek care because her family doesn't recognize the danger signs. Second, the delay in reaching a health center because there are no paved roads and no ambulance. And third, once she finally arrives, the health center is understaffed and lacks the basic medicines that could save her life. Howie's death isn't just a medical failure, it's a systemic one. That's the hard reality of global maternal mortality. But most of these deaths, over 80% in some places, are preventable. Today we're looking at what's being done about it. There's been lots of progress. Between 2000 and 2023, the global maternal mortality ratio, that's the number of maternal deaths per 100,000 live births, dropped by about 40%. In some regions like Eastern Europe and Southern Asia, these drops were as high as 75%. So we know what works: skilled health professionals and high-quality care during that critical window right after birth. We've seen many countries take bold steps. As an example, in 2022, Sierra Leone declared maternal mortality a public health emergency. They created a situation room to track every single maternal death and tackle the root causes. Chile used conditional cash transfers to make sure new mothers can afford to get to their postpartum checkups. But even with this progress, we're still far off from the United Nations Sustainable Development Goal of fewer than 70 deaths per 100,000 live births by 2030. In fact, if we stay on the current path, we'll be 2.5 times higher than that target. The burden is also very unequal. About 95% of these deaths happen in low and lower middle income countries, particularly in sub-Saharan Africa. At Dessie Hospital in Ethiopia, a mother died in childbirth every 2 weeks, a tragedy the medical team refused to accept. They discovered that long wait times for care and missing medical supplies were the primary causes. They worked hard on a healthcare improvement initiative that reduced the time it took for a doctor to see a mother from 85 minutes to just 20 minutes, and making sure there was a dedicated bed in their intensive care unit for new mothers who needed a higher level of care. They implemented the E-Motive Bundle, a series of steps designed for low-resource settings to improve the speed of response to postpartum hemorrhage by early detection and treatment. Their work reduced maternal deaths by half, proving that focused changes can save countless lives. Today we're joined by Abebe Alene, a quality improvement advisor with the Institute for Healthcare Improvement, who worked with Dessie Hospital on this effort. The views expressed on the show are mine and those of my guest. So, Abebe, welcome to Mapping Healthcare. You have a background as a nurse midwife. Today we're going to be talking about a paper that you and your team recently published, and it's about quality improvement work you did at Dessie Comprehensive Specialized Hospital. And so we'll talk about that. And I, like you, publish papers about my improvement work, but really behind every paper, there is a story that's hard to put into, the 3,000 or so words that's given by the journal requirements. So today we're going to try to unearth some of that backstory here. So Dessie Comprehensive Specialized Hospital is located about 250 miles from Addis Ababa in Ethiopia's Amhara region. It's a teaching hospital that serves about 10 million people, and it takes care of about 1,500 patients a day for emergency care, surgical, and maternity care. And so today we're talking about a healthcare improvement project that you led, which successfully reduced maternal mortality rates, so maternal deaths, by over 50%. So, give us some background about the issues around maternity care, care of pregnant women at the hospital before this work that made the problem impossible to ignore.
So thank you for this question. Ethiopia is one of the countries struggling to reduce maternal mortality. As an HI office, as an Institute Healthcare Improvement Office, we had a mission to improve the quality of maternal and newborn healthcare and to reduce maternal and newborn mortality by 30%. So when we examined our country data, we select the 10 top hospitals with the highest maternal and perinatal mortality rates. So Dessie Comprehensive Specialized Hospital was one of the contributing hospital. So by using the 2080 QI rule, we reasoned that if we focus on the 20% of hospitals or on the 20% of health facilities with the highest maternal mortality, we can reduce 80% of mortality across the country. Therefore, we decided to start by working in one hospital to generate evidence on how to reduce facility-based maternal mortality and then scale up to the remaining hospital by giving the evidences to the Ministry of Health Ethiopia. So based on the hospital's monthly report, the results showed the hospital had one maternal days every 2 weeks. Then when visited the hospital and conduct additional baseline assessments, including review of infrastructure, materials, healthcare providers, skills, and overall the system interaction. So after we conduct a baseline assessment, next we conduct a co-creation workshop with all responsible bodies, with the hospital CEO, administrator, OBGYN staffs, and referral health centers, and the zonal health department office. Finally, when we showed the results, how one mothers die every 2 weeks, and when we showed the gaps of the process of care, when we show the gaps of the system, finally we reached an agreement to address the problem through quality improvement project. So that was the story behind how we start the work in the Comprehensive Specialized Hospital.
One of the things you mentioned, the fact that one mother dies every 2 weeks, right? That's what you said. It grabs people's attention. And basically, communicating outcomes like that in a way that they grab someone's attention is really important. And the OBGYN department at this hospital manages over 500 deliveries a month, and your team tracked that specific outcome. How many days passed between maternal deaths? And data collected over 40 weeks showed that the average time between maternal deaths increased significantly from 14 days to 39 days. So you had way less women dying at childbirth. So tell us a little bit about that measure, that metric. Why was that way of measuring progress so powerful, and how did it change the mindset of the people doing the work at the front lines?
So, as you know very well, maternal mortality is a rare event. So, as a quality improvement advisor, when you are dealing with a rare event, you need to understand how to measure it. You need to understand how to calculate that data. So, measuring the time between days gives you a sense of how quickly the next event may occur. So, whenever you go anywhere to support the facilities as a coach, as an improvement advisor, you need to secure every facility members by your idea. Unless people accept your idea, they will not engage in the work. For example, if you say we had 500 deliveries per month and two maternal days, people may think, okay, 498 mothers deliver safely. But when you use a time chart and say we lose one mothers every 14 days, people becomes more alert. They begin to focus on improvement. They also shift their measurement culture, and everyone's becomes familiar with tracking time between events. So these kind of measurements are very powerful.
You got my attention for sure. And so this example clearly shows that not only is collecting data important, but how you position it and how you communicate it is really key in getting people engaged and activated. And your team addressed high maternal death rates by streamlining the consultation process. the process by which they see specialists and OBGYN providers from 85 minutes to under 20 minutes. So you got clinicians there sooner. And you also ensured the availability of essential medicines and dedicated intensive care unit, ICU beds. So, one of the striking findings from your paper was how long it used to take for seriously ill patients to get expert help and how much faster that became once your team worked on this project. Access to care and how far you can get care from specialty providers is a problem that's a worldwide issue. So I think we can really learn from that. So can you explain why some of these delays happen and what it took to make care faster?
When you are working in a teaching hospital, as you know very well, you have to balance the teaching process with actual care process. In our country, the context is a little bit different. There is unwritten hierarchy, in the teaching environment. When the mothers comes to the OBGYN department, first the midwife examine and assess her, then the midwife consult to the residence year one OBGYN student. Then the resident examines and assess the patient again. And then if he can't manage, he consults to the second year resident OBGYN student. Then after this report becomes after a long decision dilemma, because when the year one consults to year two, the year two asks about the condition, about the diagnosis of the mother. So by fearing the next question, some of the resident students taking a long time for decision. Then the second year resident also repeats the examination and assessment. Then if they cannot manage the case, they also consult to the third year OBGYN resident. Then the third year OBGYN residents expect provide a definitive management. But if they are still unable to manage that complication, they consult to a senior physician who are permanently works in that hospital, who are responsible for that hospital. So this long process costs mothers' lives. We understand that the students need to learn, the students have to learn, but it should not come at the cost of life. So we need to balance this teaching process and the actual care process. So when we presented this process map to the team, each of the residents and the midwives, it's around 85 minutes. It's too long for the mothers have the complication because within a minute we can save a life, within a minute we can lose a life. So after we understand this, we present for the teams. They recognize that this unwritten hierarchy contribute to maternal days. They agree that the third year OBGYN residents and senior physicians have nearly equal knowledge and skills. Therefore, by breaking the old process, they decided to design a new one for the mothers with preeclampsia and for postpartum hemorrhage. The midwife now directly calls to the third year OBGYN resident, avoiding the delays and helping to save lives. Then the team agreed to this change to ensure consultation within 20 minutes. By redesigning this process map, we can save a lot of lives, as you see on the outcomes. So you have to ensure also that the new redesigned systems is acceptable by all OBGYN staffs, and you need to negotiate with all staffs, including the students, because they are not a permanent staff of the hospital, but they are also the part of the providing that care. So we had to break the old process and to redesign the new process.
This point is extremely important because teaching hospitals have lots of learners there. They're really well known for the standard of care they provide and their ability to take care of people who are really sick and have severe complications. Teaching hospitals are well equipped to do that. But you brought up an issue that many teaching hospitals face, this balance between teaching and the hierarchy and patient care. So, this discussion is really an important one for all teaching hospitals to learn from. You streamlined your process and you looked at specifically high risk mothers that have uncontrolled high blood pressure, those that are at risk for excessive bleeding after delivery. So again, changing workflow where these specific women with high risk conditions get care sent to them really fast, bypassing some of that hierarchy is really an important discussion. The hospital adopted standardized medical checklists for managing complications like postpartum hemorrhage, which can lead to uncontrolled bleeding, and preeclampsia, which could rapidly spiral into uncontrolled blood pressure that could threaten the life of the mother and the baby. And your study found that use of these checklists really changed things. You also increased the availability of essential medicines at the point of care. But, this wasn't just about checklists of medications. It was also about leadership, teamwork, making sure the right resources were available at the right time. So, what did you learn about how leadership and culture influence patient safety from some of this work?
Yeah, you're right. Because, without the leadership engagement, we didn't achieve that outcome. So the engagement of the hospital leaders was very significant, and that was the very crucial part of the work. You cannot achieve your goal with only department staff. There are many gaps that requires the leadership involvement in the department, from starting the simple paper of preparing the checklist. So that checklist needs a paper. The paper needs to purchased by the finance process by the leadership. So from the simple one, you need the leadership engagement involvement strongly for any quality improvement work. So when we started this work, yeah, we presented all the data and shared an action plans with the leaders. That includes ensuring the availability of materials, building hand washing facilities, renovating rooms, redesigning materials, spacing child health areas, and maintenance, ensuring the privacy of each mothers by preparing private rooms. We had a meeting every 2 weeks with senior management and the leaders. So during these meetings, the department team also presents the report about their work and how they were improving the care process. So the leaders also reported on how many problems they had addressed and resolved. What I introduced the concept to the leaders is the Gamba work. Gamba work means just visiting the departments every 2 weeks in the OBGYN and the neonatal intensive care unit department. So they interviewed the frontline healthcare provider about the challenge they faced and addressed many of the issues immediately when they returning the office.
Yeah, so it looks like your team effectively engaged leaders and, your
Yeah.
work really made a huge difference. Your team reduced maternal mortality rates by half in these hospitals, but not everything went smoothly along the way. So, can you talk about a moment when things didn't work as planned and how those setbacks helped your team learn and improve?
Yeah, you're right. It is a long journey. So at the beginning, when we start recording the consultation time, some of the team members were frustrated. They felt that this work might affect individuals directly and could be used for the blame. Throughout the process, we emphasize that the data were collected for improvement, not for the blaming. Over time, especially when days occurred, they saw that our focus was on improving care process rather than targeted individuals. Then this helped build trust. I remember one time when I work out from the OBGYN department, one of the midwife called me and he said, Abebe, before your organization project, we heard a family crying every 2 weeks. Now, thanks to your work, we heard it every 2 months. In Ethiopia, when the mothers die, the families are crying loudly and everybody's collecting in the hospital. That's our culture. So before our project, I heard the family crying every 2 weeks. It's so emotional and it's so disturbing for healthcare providers to hear the family crying when the maternal days happens. So it's not easy making that crying within every 2 weeks to 49 days. But at the beginning, they were frustrated. If you use this data for learning, not blaming, the teams become stressed and they work from their heart and from their passion. So that was a challenge, but throughout the time, we avert that challenge.
You brought up such a profound thing there. You mentioned heard the families
Yeah,
crying, and so the grief, the immense grief that not only families face,
yeah,
but also the healthcare workers that work with these families face, and the distress this causes the clinical community. You really brought up some important things about leadership. You mentioned Gemba walks, and that's a concept from Toyota, which basically you have leadership walk in frontline care settings, right? In Toyota, it would be the factory floor. In healthcare, it would be the ward or the clinical setting, and they would walk there and talk to people working at the front lines to learn some of the challenges. So really, these leadership walk rounds, Ogemba walks, the Japanese term there, really are evidence-based practices to change culture and behavior. One of the concepts you spoke about that was important was this concept around not setting blame, not using data for blame. You want people to be accountable, of course, for negligence and practices that might be unethical. But the majority of people working in these clinical settings, it's basically systems that don't work. So collecting data and not using those data for blame, that's really important. And so for listeners wondering what they should take away from your study, tell us what's the one big lesson? What can other hospitals, health systems, and communities learn from your experience to help keep mothers safe during childbirth?
In this work, we learn a lot of things. We need to avoid unnecessary process in the maternal and newborn health area. The maternal and the newborn health area is very time sensitive. So we need to act quickly, and we have to be responsive for the complication of mothers and newborns. So we need to redesign our old process. In the teaching hospital, we need to balance the teaching process and the actual healthcare process according to privacy, according to content of care. The neonatal intensive care unit and the OBGYN department have to communicate closely because they serve the same clients. They serve the mothers and the newborns. So when the mothers comes to the hospital, she didn't differentiate where is the NICU room, where is the OBGYN room. She also said if she lose her neonate, she said, I lost my neonate in Dessie Comprehensive Specialized Hospital. So we have to work as a team. If we are not working with the referral health facilities, we can't improve the mothers and newborn lives. As a teaching hospital, as a comprehensive specialized hospital, there are a lot of physicians in that setup. So they have to go out to outreach for clinical mentorship. If the primary healthcare level becomes strong, the referral case reduced and they can managed at the primary healthcare level.
That point is really important that, you can't just work to strengthen tertiary care systems. You have to have, you mentioned outreach to other levels of care that are actually referring into the tertiary healthcare system. So you have overall elevation of health in our population if you strengthen all levels of care, and that's a powerful lesson. I want our listeners to also leave with an understanding of the region that you work in. And Dessie Comprehensive Specialized Hospital is a crucial hub for specialized medical care for Ethiopia's Amhara region. And we end each episode by trying to understand the region a little bit. We talk about the place our guest works in. So tell us a little bit about Ethiopia's Amhara region, what's special about it, and what someone new to the area shouldn't miss if they visit you.
So Amhara Regional is one of the largest region in Ethiopia. So it has a multicultural diversity in the region. If someone visits Ethiopia, try our coffee. The origin of the coffee is Ethiopia. So you will find the true coffee in our home, and you have to taste the traditional food like dorot and other traditional food. Dessie also surrounding with lake, especially one of the great lake, Stephanos Lake. So if you go to Dessie, you will have the chance to catch the fish, and you can make the fish at the beach.
I'm a coffee fan, so of course, when you mentioned the word coffee, that immediately got me more alert. Thank you, Abebe, for your time. It was such a privilege highlighting your work on mapping healthcare today.
Thank you, Ulfat.
So that was Abebe Alene telling us about work in Ethiopia that reduced maternal mortality rates by over 50%. You might be thinking, that's a challenge only in developing countries. But the United States actually has the highest maternal mortality rate of any high-income nation. While countries like Norway and Switzerland have rates near 0 or 1, the US rate is around 22 maternal deaths per 100,000 live births. And the data show a startling divide. In the US, Black and Native American women are more than twice as likely to die from pregnancy-related causes compared to white women. This isn't about biology. It's about bias, racism, poverty, and disparities in access to quality care. There are two major things other wealthy countries do well. First, midwives. A midwife is a trained healthcare professional, a non-physician, who supports mothers and newborns before, during, and after childbirth. In most high-income countries, midwives outnumber OBGYNs and are the backbone of reproductive care. They provide 80% of essential maternal care and can prevent 40% of maternal deaths. In the US, we have an undersupply of midwives and many maternity care deserts where there are no clinicians to deliver babies at all. Second, the postpartum period. 2/3 of maternal deaths in the United States happen after the baby is born, sometimes up to a year later. The US is the only high-income country without a federally mandated paid leave policy. So while a new mother in Norway gets a year of paid maternity leave, a mother in the United States often needs to go back to work while her body is still healing, and her risk for conditions like heart failure or depression are still high. Just like we've invested billions of dollars into cancer and heart disease research, we need a national commitment to maternal health that addresses not just medical care, but also social safety nets like education and housing. So here are 3 things you should take away. First, care doesn't end at the hospital exit. The postpartum year is the most dangerous time for new mothers, and guaranteeing care like home visits from nurses and midwives will help keep new moms safe. Second, health disparities. We can't fix the maternal mortality crisis without tackling biases and poor access to care that make it so much more dangerous for Black and Native American women to give birth. And finally, policy. Things like paid parental leave and healthcare coverage are life-saving interventions that reduce stress, improve mental health, and ensure women don't skip life-saving checkups because of the cost. Mothers deserve better. We have the medical knowledge about what works. What we need now is the political and social will to make sure that every woman who starts a pregnancy gets to see her child grow up. Thanks for tuning in. This was your host, Dr. Sheikh. You were listening to Mapping Healthcare on KDRT 95.7 FM. Connect with me on Instagram at Mapping Healthcare. If you enjoyed this episode, please leave a review. It helps get the show in front of new people.